respected doctors. So in the next few minutes, we will discuss about the diabetic neuropathy. See, you all know the different complications of the diabetes, both the microvascular and the macrovascular. And this diabetic neuropathy is the most common and most troublesome of all diabetic complications. It affects more than 50% of all patients with diabetes at some time or other in their lifetime. So it is one of the commonest complications of the diabetes. It's a painful complication and also a hidden and a secret complication because of the erectile dysfunction associated with the diabetic neuropathy. See, the definition is the presence of the symptoms and or the signs. So some people, they may not be having any symptoms, asymptomatic, but they have the signs of the neuropathy. So if the patient is having both the symptoms and the signs, well and good. But even in the asymptomatic individuals, you are supposed to diagnose the diabetic neuropathy based on the signs. So signs of the peripheral neuropathy dysfunction in people with a history of the diabetes after the exclusion of the other causes like anemia or alcoholism, etc. So if you classify the diabetic neuropathy, there are the different types of the neuropathies, and the most important group is the diffuse neuropathy. It is the distal symmetrical polyneuropathy. That is the most commonest form of the neuropathy we often see in the diabetic individuals. It may be of small fiber neuropathy or a large fiber neuropathy, and most common is the mixed small and the large fiber neuropathy. So clinically, we may not differentiate whether it is a small fiber or the large fiber. Most of the times, it is a mixed one, like your diabetic foot. Say the diabetic foot is a mixture of vasculopathy, neuropathy, and infection. In some people, the vasculopathy is a more dominates. In some people, the neuropathy dominates. In the same way, here in the distal symmetrical polyneuropathy, some people may have the small fiber neuropathy to about 20 to 30%, and 70% about the large fiber neuropathy, or the vice versa. And autonomic neuropathy is very, very common in the diabetic individuals, especially elderly diabetic individuals. Diabetes with the neuropathy, diabetes with vasculopathy. So they have the autonomic neuropathy, and autonomic neuropathy of different organs. Maybe the bladder involvement, or the erectile dysfunction, or the gastritis, or gastrointestinal involvement like the constipation, or the diarrhea, etc. So sometimes these people may have a cardiac autonomic neuropathy is also there. So we consider that as a cardiac autonomic neuropathy. So autonomic neuropathy of different organs. Then the next subgroup is the mononeuropathy. It is not that common, but often we see it is an isolated cranial or the peripheral neuropathies, maybe the third cranial nerve neuropathy or the fourth cranial nerve or the sixth cranial nerve, etc. Are the different peripheral nerves. Mononeuritis multiplex, it almost presents like in some part of the body. These people have the tingling and the numbness sensation. Radiculopathies are very common in the chronic diabetics. A polyradiculopathy, again atypical forms. It is a radiculoplexus neuropathy, just like your sciatica or the lumbago. So lumbosacral polyradiculopathy or the proximal motor amyotrophy, where the people may not get up from the sitting position because of the weakness of the proximal thigh muscles. So thoracic radiculopathies, these are also common. So these people will have the root pains in the thoracic area. So if it happens to be on the left side, so sometimes we miss it as a angina pectoris or a cardiac pains. A non-diabetic neuropathy is common in the diabetic individuals. So pressure palsies like your carpal tunnel syndrome or the tarsal tunnel syndromes, etc. A chronic inflammatory demyelinating polyneuropathy, just like your Guillain-Barré syndrome. Radiculoplexus neuropathies and acute painful small fiber neuropathies, maybe the treatment induced like your INH neuropathy and etc. or steroid neuropathy, etc. So these are the different types of the neuropathies we often see in a diabetic individuals. So a diffuse neuropathy, a mononeuropathy, autonomic neuropathy, radiculopathy, and then the non-diabetic neuropathies which are common in the diabetics is also very common in diabetic individuals. Let us spend some time on the DSPN, that is the diffuse symmetrical polyneuropathy. This is one of the commonest forms. The most common presentation of the diabetic neuropathy, a chronic sensory motor neuropathy, but symptoms are predominantly sensory. There is a glow and stalking pattern of the involvement. The positive symptoms include the pain, pricking, burning, or lancinating in the nature, a numbness, sensation of the walking on the cotton wool. So these are all very common in our clinical practice. So most of our diabetic individuals, when they have the DSPN, so they will tell you that they have the pricking sensation in the feet, a burning sensation in the feet, some lacerating pain, numbness, sometimes no sensation of the walking on the cotton wool. And they feel uncomfortable even when they touch the blankets also while they are on the bed. So these are all the positive symptoms in the pain. Sometimes no, they will have the negative symptoms also because loss of the sensation or anesthesia. So that is also there. So paresthesias are also common and allodynia can occasionally occur. In later stages, there is amelioration of the pain and gradual loss of the sensations. So this is the bad. So once they have the loss of the sensations, so they are more prone for the injuries. Even a trivial injury, so they may not notice it, and that will turn up into a diabetic foot ulcer and finally the amputation also. So this is the diffuse symmetrical polyneuropathy presents in most of the diabetic individuals, the most common presentation of the diabetic neuropathies. As I told you earlier, a small fiber neuropathy and the large fiber neuropathy, but most of the people, they have the combination of the small and the large fiber neuropathies. So when the small fibers are affected first, so they present with the burning pain, lancinating pain, paresthesias, cutaneous hyperesthesia, loss of pain and the temperature sensation, and some ulcers. So whenever the patient complaining of these things, so you think that the small fibers is affecting the first and most defect is in the small fibers. When it involves the large fibers, a loss of the vibration sense when you examine the tuning fork, a loss of the proprioception, loss of the reflexes like your knee jerk or the ankle jerks, etc., and slowed nerve conduction velocity. So these are the fibers, large fibers affected effects. But in the clinical practice, most of the people, they come in a late stage, so they will have the both small fiber and the large fiber. So they will have the burning pain, lancinating pain, paresthesias, loss of pain and temperature. And again, when you see the reflexes, so loss of the reflexes or rareflexia or hyporeflexia, and then the loss of the vibration sensations. That means a mixed small and the large fiber involvement will be seen in most of our diabetic neuropathies. So this is the motor neuropathy can lead to the small muscle wasting and the deformities. See the wasting of the intraosseous. So you can clearly see the between the toes. So there is a wasting of the intraosseous. So this is the motor weakness. So not only your sensory symptoms here, it's a motor neuropathy. So the neuropathy, sensory neuropathy, motor neuropathy, autonomic neuropathy. See the hammer toes. So this is again because of the motor neuropathy. So with these toes, when they walk, they are more prone for the pressure effects. And then they will be land up with some callus formations and then the small ulcers formation. And then these ulcers will become infected and then the diabetic foot initiation will be there. See the patients with the deformities due to the motor neuropathy can develop the ulcers at the abnormal pressure points, which go unrecognized due to the loss of the pain sensation. Most of our diabetic individuals, especially in the rural India, when they walk barefoot walking, so they may not appreciate the pain sensation. So that is the reason they come at a later time with a very foul smelling diabetic foot ulcers. See, this is the toe ulcer, erosions on the dorsum of the toes. And then the neuropathies, common mononeuropathies, the cranial nerves, third, fourth, sixth, and the seventh cranial nerves. In the thoracic, mononeuritis multiplex. In the peripheral, lateral cutaneous nerve of the thigh, peroneal nerve, soral nerve, sciatic nerve, femoral nerve, and in the upper limbs, median nerve and the ulnar nerves. So these are the common nerves involved in the diabetic neuropathies. How to compare the mononeuritis and the entrapments? See, the mononeuropathy is a sudden in onset, whereas the entrapments is a gradual in onset. Pain is acute in mononeuritis and the chronic in the entrapments. Mononeuritis multiplex occurs here in the mononeuritis, whereas the very, very rare in the entrapment neuropathies. And mononeuropathies resolve by themselves, whereas entrapment neuropathy persists without the intervention. You need some splints or some surgery or some intra-articular injections like steroid injections in those areas, entrapment areas. So that is all very important in the management part of the entrapments. Whereas in the mononeuritis, so the physical therapy or your physiotherapy will help in mononeuritis multiplex. So these are the common differentiation points between the mononeuritis and entrapment neuropathy. So this is the third cranial nerve palsy. It's a very sudden in onset and recovery is the rule. So don't worry about these third cranial nerve palsies. So they may be associated with the headache. A mild headache will be there. And pupils usually spared. If you see the pupillary reflex, so that is intact because the fibers supplying the pupil are outermost and hence less susceptible to the ischemia. Incomplete ptosis, not the total ptosis. Hence diplopia may not be a prominent symptom. And full recovery is the rule. So this is the sixth cranial nerve palsy. See the presence with the diplopia. Examination reveals inability to abduct the affected eye. So you concentrate on the first one. See the right eye is the center, whereas the left eye, the adduction is there. In the second picture, both the eyes are at the center. And the third picture, if you see the left eye, so abduction is there, whereas the right eye, only adduction. So this last right eye, abduction is lost here. So that is the sixth cranial nerve. So because of this loss of the abduction, so these people will have the diplopias. Diabetic amyotrophy. So this is also very common in a chronic diabetics individuals. It is a proximal motor neuropathy, also called as the Bruns-Gardner syndrome. Acute or subacute onset to the severe neuropathic pain. Mostly it is subacute. A profound wasting and the weakness of the quadriceps femoris. See, observe both the thighs. So the left thigh and the right thigh. Here the right thigh is affected. There is a wasting and the loss of the knee jerks. Usually it is a unilateral. A multifocal involvement of the lumbosacral roots, plexus and the femoral nerve will be there and recurs spontaneously. So this is a diabetic amyotrophy. Here the treatment is control the blood sugars effectively and the patient is having other comorbidities like the hypertension or dyslipidemia or smoking. So you advise them accordingly. So that's how this can be controlled and the physiotherapy also can help them. So this is the proximal motor neuropathy. We often see in some of the chronic diabetic individuals. See, hyperglycemic neuropathy, even the high blood sugars itself, they cause the neuropathy. It's a reversible condition because hyperglycemia will be reversed with your interventions. When you start the insulin therapy, so there will be the euglycemia. So because of the euglycemia, this neuropathy will disappear. So it is a reversible symmetric neuropathy found in poorly controlled diabetics. Presents with uncomfortable sensory symptoms in the legs. So the difference between the hyperglycemic neuropathy and the diabetic neuropathy is, in diabetic neuropathy, it mostly may be the unilateral. Whereas here it is the bilateral hyperglycemic neuropathy. It clears rapidly under controlling the sugars. Narrow conduction study shows slowing of the narrow conduction velocity. So now move on to the autonomic neuropathy. This is the very, very common. And left untreated, sudden cardiac deaths are very common because of the autonomic neuropathies. So that is the CAN, that is cardiovascular autonomic neuropathy. So the people will have the tachycardia. Always the resting heart rate will be the more than the 100, more than the 90. At any given time, you see the heart rate, it will be 110, 120 or 108, etc. In uncontrolled diabetic individuals, elderly individuals, that means this fellow is having CAN, cardiac autonomic neuropathy, at high risk of getting the sudden cardiac death. Cardiac denervation, orthostatic hypotension. So that is the reason in all the chronic diabetic individuals, when they happens to be in hypertensive also, so you have to check the blood pressure in all the three postures. So supine position, sitting position, and the standing position to rule out the orthostatic dysfunction. So orthostatic hypotension. So when the fellow is having orthostatic hypotension, so indirectly it tells that that patient is also having autonomic neuropathy. So check the blood heart rate. So that will be more. So this is the very common here, and also your Valsalva maneuvers or breathing, heart rate variation during the breathing, heart rate variation during the posture, heart rate variation during the Valsalva maneuver. So all these things can help you whether the fellow is having the cardiovascular autonomic neuropathy or not. The skin temperature reversal, dry skin, and the dependent edema. So these are the features of the CAN, that is the cardiovascular autonomic neuropathy. Very, very important. You should diagnose the CAN. Otherwise, these people will have a lot of the arrhythmias and the sudden cardiac deaths. Now coming to the second important autonomic neuropathy is a very troublesome in our diabetic individuals is the gastrointestinal autonomic neuropathy. So these people will have the esophageal dysmotility like your GERD syndromes, gastroparesis diabetic aurum. So these people gets the vomitings, that the diabetic vomitings, constipation, the diabetic constipation, diabetic diarrhea, and sometimes alternate diarrhea and alternate constipation. So 1 month or 2 months they will have the diarrhea, and the next month they will have the constipation, or 1 week constipation, second week diarrhea. So this is also very common in diabetic individuals, and the fecal incontinence. So these are the gastrointestinal autonomic neuropathies. So these occurs in the chronic diabetes and controlled hyperglycemia. If you keep the HbA1c above the 10 or the 11 for so many years, so definitely these people are good candidates to get the autonomic neuropathy. So our aim is not to have the autonomic neuropathy in our diabetic individuals by keeping our HbA1c around 6.5 for longer periods. So other autonomic neuropathy, we discussed about the CAN, we discussed about the gastrointestinal, down the genitourinary. This is also very common. It's a neurogenic bladder, erectile dysfunction, cystopathy, and retrograde ejaculation. So these are the genitourinary. Out of them, the cystopathy is very, very common in our diabetic individuals. So very often they will have the cystitis, they will have the urge to urinate, and they urinate very small amounts, and frequency of the urination, nocturia, dysuria. So these are all very features of the cystopathies. And coming to the metabolic autonomic neuropathy, hypoglycemia unawareness. This is a very, very dangerous one, because even though the fellow is in the hypoglycemia, he may not recognize that he is in hypoglycemia. So that means adrenergic hypoglycemia he surpassed. See, hypoglycemia is of two types. One is adrenergic hypoglycemia. The second one is neurogenic hypoglycemia. In adrenergic hypoglycemia is a protective mechanism. So the people will have palpitation, tachycardia, restlessness, hypersweating, and they want to eat something, and they are conscious. So once they are conscious, so they know that I am in a condition of the hypoglycemia, and then immediately they eat by themselves, and they correct the hypoglycemia by themselves. So that is a good part of the, which part of the hypoglycemia? Adrenergic hypoglycemia. Because they have the tachycardia, palpitation, restlessness, sweating, etc. And some of the individuals, especially the elderly diabetics, a chronic diabetics, whose HbA1c is beyond 11 or 10 for many years, so they will land up with the neuroglycopenic hypoglycemia. So that is hypoglycemia unawareness. So they may not recognize the hypoglycemia by themselves. So the blood sugar will fall to 20, 30, 40. So what will happen to the body? So they will be irritable, and they will be comatose, and there will be the froth in the mouth, and they may develop the convulsions, and definitely they have to be admitted in the hospital, and hypoglycemia should be corrected by the doctors by introducing 25% dextrose, or maybe by other means, or some steroid injections or the glucagon injections, etc. So they need hospitalization. Suppose if they are living alone, if they get the neuroglycopenic hypoglycemia, so if the 25% dextrose was not given immediately, so what will happen to their life? They are going to die. So with a prolonged hypoglycemia with the 10 or 20 or 40, so definitely there will be the death. That is also possible. So most of the elderly individuals, so by the time the family members found them he is dead, he is already in the profuse sweating. So they thought that it could be a reason of a chronic myocardial infarction or a sudden cardiac death. So this sudden cardiac death or the acute myocardial infarctions like picture is because of the severe hypoglycemia, neuroglycopenic hypoglycemia. So that is also very common in elderly individuals. So that is the reason I told you several times that when the people are living alone, when they are very elderly, and please keep the HbA1c not at 6.5 like the young diabetics, but at 7.5 or even at the 8 also. That means you are keeping the blood sugar at fasting at about 130 or 140, and the postman at about 200 or 220. So that means even though they miss the food, even though the dose is the more, so they may not reach the hypoglycemic levels. So you have to see that Avoidance of the hypoglycemia is very, very important in elderly living alone rather than your hyperglycemia. Hypoglycemia unresponsiveness also, this is a part of the autonomic neuropathy, and half, that is hypoglycemia associated autonomic failure. Now the cutaneous autonomic neuropathy, a distended veins on the foot due to the AV shunting. So some elderly population or geriatric population, the veins will be happily seen. All the veins will be visible on both the hands and the feet also. So this is because of the cutaneous autonomic neuropathy. Okay. So the distended veins on the foot due to the AV shunting. So sweating disturbances. So some of the diabetics know they will have a sweating disturbances. Areas of the symmetrical anhydrosis and gustatory sweating. Sorry. So this is the skin autonomic neuropathy. Then the pupillary autonomic neuropathy. So the decreased diameter of the dark adapted pupil, and you will have the Argyll-Robertson type pupil. So ARP, Argyll-Robertson pupil. Your accommodation reflex will be the present, and pupillary reflex will be the absent. ARP, A, accommodation, R, reflex, P, present. Now PRA, that is pupillary reaction last. So this is your Argyll-Robertson pupil. Now the diagnosis of the diabetic neuropathy, ADA or the American Academy of the Neurology recommend at least one parameter from each of the 5 categories. So symptom profile, neurological examination, quantitative sensory testing, nerve conduction studies, quantitative autonomic function testing. So these are very, very important. Out of them, we do the symptom profile. The patient will tell all the symptoms. You please examining with the 10 grams monofilament or with your tuning fork, 128x tuning fork, and then your reflexes. So these are all your neurological examination, or your diplopia, or your pupillary examination, etc. And then the quantitative sensory testing, nerve conduction studies, we get it from the labs, and then the autonomic function test. So these you have to order outside. Diagnosis of the diabetic neuropathy. All patients with the diabetes should be screened for the distal symmetrical polyneuropathy, starting at the diagnosis of the type 2 diabetes and 5 years after the diagnosis of the type 1 diabetes, and at least annually thereafter. See, I told you several times that what are all the complications we have in the diabetes, they may be present even at the time of the diagnosis of the type 2 diabetes. Because type 2 diabetes, they present as the asymptomatic nature. So by the time the patient comes to you, it could be a 2 years history or the 5 years history or the 10 years history of the diabetes life. We don't know the exact duration of the diabetes. Whereas the type 1 diabetes, it's an acute presentation. So the type 1 diabetes is insulin deficiency, insulin loss, no insulin at all. So these people will present with your classical 3 Ps of your polyuria, polyphagia, polydipsia, plus unintentional weight loss of 5 kgs, 6 kgs, 7 kgs, and most of the times they may present with a DKA also, with profuse dehydration. So in the pediatric groups, whenever you see a fellow with a severe dehydration without a history of the gastroenteritis, please think of DKA. So get the blood sugar done. It should be 300, 600, 700, 800, etc. If you ask the leading question to the mother, is there any history of the diabetes? No. So that means first time detected the diabetes with a DKA. So that is the presentation of your type 1 diabetes. Whereas the type 2 diabetes, sometimes I get the referrals from the ophthalmology friend. So this fellow visited the ophthalmologist for the loss of the vision. And the ophthalmologist detected diabetic neuropathy. It is not non-proliferative diabetic retinopathy. It is almost proliferative diabetic retinopathy, retinal detachment, retinitis, or retinal artery occlusion, etc. And that retina surgeon or an ophthalmologist asked the leading question to the patient that, what is the duration of the diabetes in you? I'm not a diabetic. First time I'm hearing that I am a diabetic. So if you ask the sister to get the blood sugar done, it is 400, 500, etc. And if you get the HbA1c, it will be 16%, 17. So your target is 6.5. So that means this fellow has been living with unrecognized, unnoticed diabetes for years together. So by the time they had the proliferative diabetic retinopathy and then the vision loss, then they approach it to the ophthalmologist. The same examples will happen to the nephrologist, to the cardiologist, to the neurologist, to the general surgeon. When they approach to the diabetic foot ulcers, uncontrolled foot ulcers, when they approach to a general surgeon, then he asks the direct question, what is the duration of the diabetes, by seeing that foot. So he said, no, I am not a diabetic. So if they check the blood sugar, 350, 400, 500. And if you check the HbA1c, 14, 15, more than that 10. So that means this diabetic foot is, that foot ulcer is because of the diabetes. So these are very, so many common, so many examples are there in our clinical practice, that the take home message to all of you is 40% of your diabetic individuals, they present with the complications at the time of the diagnosis. So this holds good for your type 2 diabetes, adult practice. Whereas the type 1 diabetes, mostly they present with an acute symptoms only. Maybe 5 years, 5 days, or 1 week, 2 weeks, maximum less than the 1 month presentation. So no mother will keep the child with polyuria, polyphagia, polydipsia, weight loss at the house. Immediately they approach to the doctor because of the acute presentation, and definitely the doctor will diagnose the diabetes, and then they will have a early diagnosis of the diabetes, and then the early initiation of the insulin, and definitely they do well in the next few months or the few years. But definitely the long term, again the follow-up is important. So most of these people, they are not on good follow-up. So definitely their HbA1c is around 10 for most of the times. The fasting will be 150, 200. Postponed will be 250, 300. And then they are not obeying your dietary approaches. So definitely they will land up with diabetic nephropathy, diabetic retinopathy, diabetic vasculopathy. So by the time they are 30 years or 40 years, I think they may not live beyond 50 years unless they keep the blood sugars very tight. So that is the duration of the type 1 diabetes. But in the beginning, diagnosis is much early in the type 1 diabetes. The response is much early because of introduction of the insulin. But in type 2 diabetes, so most of the people, they present with the complications. So some people, they present with the neuropathy complications also. So directly, straight away, they present with the diabetic neuropathy complications. Assessment should include a careful history and either temperature or pinprick sensation, a small fiber function, a vibration. So that is a large fiber function. All patients should have an annual 10 grams monofilament testing to assess for the feet at risk for the ulceration for amputation. Symptoms and signs of autonomic neuropathy should be assessed in the people with the diabetes, starting at the diagnosis of the type 2 diabetes and 5 years after the diagnosis of the type 1 diabetes, and at least annually thereafter, with the evidence of other microvascular complications, particularly kidney disease and diabetic peripheral neuropathy. See, in our routine practice, whenever you see a diabetes with one complication, you check for other complications. So if the patient is having the diabetic neuropathy symptoms, and you examine and your diagnosis is diabetic neuropathy, don't be happy with that diagnosis alone. So why not retinopathy? Why not nephropathy? Why not cardiomyopathies? Why not CVA? So etc. So unless you ask the leading questions, so definitely you are missing those complications also. Okay. Assessment of the peripheral nerve function. So simple, very good picture here. See the DP and how it acts, hands and gloves sensation. And then the monofilament. So that is a 10 grams monofilament. And then the vibration sensation. So that is with your tuning fork. So then the pin test, the pin prick, that is the pain sensation. And then the touch sensation. Then the thermal test, that is your temperature. And then the position sense. It's a beautiful picture you should apply in your clinical practice. So whenever you are thinking of the diabetic neuropathy, you please see that. So examine with the 10 grams monofilament, examine with the tuning fork, with the position sense, with the temperature, with your cotton, with your touch sensation, or with your needle, with the pain sensation. Very easy. Within 1 minute we will get it done, all these things. But it gives a very valuable information in your nerve functions. See, you don't require that CT or MRA or 2D echo or costly examinations. You just need a 10 grams monofilament, one tuning fork, and then your mindset to examine the nerves. So it's very easy. See, this is the monofilament test. So the name given to this monofilament test is Siemens-Weinstein monofilament. So these are the spots. So on the sole of the foot, on the great toe, and the ball of the great toe, on the third toe, and the fifth toe. So these 4 areas, 4 plus 4, 8 spots on the sole. You have to examine whether the fellow is having the neuropathy or not. Integrity of the reflex arc should be evaluated by testing the ankle jerk, often absent in the normal elderly individuals. So don't expect the ankle jerk to be present in all the individuals. So that may be lost in elderly individuals. That doesn't mean that this fellow is having very severe neuropathy. So for young individuals with the symptoms of the diabetic neuropathy, if the ankle jerk is lost, so definitely it is of severe grade. Motor neuropathy in the feet can be assessed by looking for the wasting of the small muscles. I have shown you one picture. So loss of the interossei wear and deformities such as the hammer toes, I showed you. A form of power testing is not used. So the DD of the distal symmetrical polyneuropathy, this is the most common form of the polyneuropathy. So not all because of the diabetes. So something else sometimes. So sometimes it may be the congenital and familial. So the name given to the syndrome is Charcot-Marie-Tooth syndrome. Traumatic or inflammatory. So entrapment syndromes, sarcoidosis, leprosy. Even today, lot of the people in India are leprosy positive. Okay. Lyme disease, even though the incidence has reduced drastically, but still leprosy is there. HIV. So HIV again, so HIV, the incidence has reduced very drastically, but still a lot of the people are HIV positive. So HIV, leprosy, sarcoidosis, entrapment syndromes, they are very, very common DDs for your distal symmetrical polyneuropathies. Neoplastic, carcinomas, paraneoplastic syndromes, myelomas, amyloidosis, leukemia, lymphoma. So nowadays, malignancies are increasing in the trend. So definitely, so these are also reasons for to get the distal symmetrical polyneuropathy. So metabolic and endocrine, these are very, very important. Uremia, that is your CKD, vitamin B12 deficiency, hypothyroidism, and porphyria. So out of them, the first 3 are very common in our societies. CKD is very common because of the uncontrolled diabetes, etc. Hypothyroidism is so common, and vitamin B12 deficiency maybe because of the chronic alcoholism or chronic metformin therapy also will cause the B12 deficiencies. Vascular and the toxic alcohol is a very, very common. Vasculitis, heavy metals, hydrocarbons, therapeutic drugs. So these are all the causes for your vascular wise or the toxic wise. And autoimmune, antiphospholipid antibody syndrome, a chronic inflammatory demyelinating neuropathies, and multifocal motor neuropathy or Guillain-Barré syndromes. So these are the common DDs of your distal symmetrical polyneuropathies. Again, I am repeating. So not all the distal symmetric polyneuropathies are because of the diabetes. So you have to think of this congenital, familial, traumatic, inflammatory, neoplastic, metabolic, vascular, toxic, and sometimes autoimmune. So atypical features such as motor, greater than the sensory neuropathy, rapid onset, or asymmetrical presentation warrant the referral to a neurologist. So the diagnostic of the autonomic neuropathy. So it's very easy to diagnose autonomic neuropathy clinically, but it's very, very difficult to diagnose the diabetic autonomic. There is no single test to diagnose the diabetic autonomic neuropathy. See, I told you the CAN. So CAN stands for cardiac autonomic neuropathy. So 3 tests of the heart rate control. The parasympathetic. Heart rate variation on deep breathing, on standing, and Valsalva maneuver. So by them, you can diagnose whether this fellow is having a cardiac diabetic neuropathy or not. And 2 tests with the BP control. BP response to standing at the passive tilting or sustained hand grip. Okay. So the BP has to be detected in the supine, standing, and the sitting position also to rule out any orthostatic hypotension. Again, a feature of autonomic neuropathy. So no test was found to be sufficiently standardized for evaluation of the pseudomotor, gastrointestinal, genitourinary, and pupillary responses in the routine practice. So mostly the autonomic neuropathy, with your experience and with your vision to detect the autonomic neuropathy, you have to ask the different questions and then you assess whether this fellow is having autonomic neuropathy or not. See, suppose a chronic diabetic presenting with a diarrhea, presenting with the constipation, presenting with the vomitings. So you don't put a diagnosis of vomitings for gastroesophageal reflux disease, and for this diarrhea, it's maybe the traveler's diarrhea or amoebic diarrhea. For this constipation, maybe because of your low fiber, etc. So common diagnosis for all these things in a chronic diabetic is diabetic gastrointestinal autonomic neuropathy. So the answer is control the blood sugars very effectively. So automatically 50% of these lesions will control by themselves. And then if they need, so you can put ondansetron or your domperidone for the vomitings or for the constipation or for the diarrhea, etc. asymptomatic treatment. Okay. So this is the very, very important. So referral to a gastroenterologist is not necessary in this population because all these gastrointestinal symptoms are because of the autonomic neuropathy caused by uncontrolled diabetes. So it is your diagnosis and you are the boss to treat these conditions. So this is very important. So whenever a diabetic, chronic diabetic presents with the different neurological symptomatology, so you yourself is the 90 to 95% sufficient to control these problems. For follow-up with the cardiac autonomic neuropathy, the following tests has to be done. HR response to the deep breathing, Valsalva, and postural BP testing. Staging of the autonomic neuropathy. In the early stage, the response during the deep breathing alone, abnormal to the heart rate during the deep breathing alone. Intermediate stage, a Valsalva response abnormality. And severe stage, a postural hypotension. So the presence of the postural hypotension means the patient is in severe autonomic neuropathy. So the management of the diabetic neuropathies, so first and foremost is your glycemic control. So it's a proven benefit. Then the symptomatic treatment. Okay. Then the agents that restore and improve the nerve function and avoidance of the neurotoxins. So all the four can be done by you people as diabetologists. So control the blood sugars effectively, give the symptomatic treatment, and agents that restore and improve the nerve function and avoidance of the neurotoxins. Most important neurotoxin for chronic diabetics is alcohol. So avoidance of the alcohol in chronic diabetics. So these are the very, very important. Glycemic control treatment with the insulin in subjects with the disabling neuropathic symptoms may help in relieving the symptoms in excess of what can be expected from the glycemic control because of the effects of the insulin as growth factor and immunomodulator. So when the fellow's blood sugars are beyond your targets, so definitely the insulin will help you in reducing the blood sugars very effectively. Not only in that way, so that insulin also acts as a growth factor and immunomodulator. But sometimes insulin may cause neuritis also. So that we consider as the insulin neuritis. However, abrupt improvement in the glycemic control, especially in patients with very poor glycemic control, may be associated with the transient worsening of the neuropathic symptoms, also referred to as insulin neuritis. So insulin neuritis is a transient one. So resolves by themselves. So you need not worry about the insulin neuritis, but you have to know that. So after starting your insulin therapy, some people they may present with the neuritis pictures and don't stop using the insulin. So continue the insulin, and this is only the transient period and self-limiting. Painful neuropathy is difficult to manage because we have some drugs in our hand like tricyclic antidepressants we use gabapentin, pregabalin, and also use the carbamazepine, etc. But very few people will get the benefit. Most of these drugs will have the side effects like pedal edema, like tongue sensations, last, or some giddiness, some vertigo, some paresthesias, some gastrointestinal side effects, some sleep disturbances. So these are very common with these drugs. So it's very difficult to manage. No single agent is universally effective. Most patients require the combination therapy. Medication should be added in a stepwise manner at 2 to 4 week intervals. Non-pharmacological management, including the psychotherapy, acupuncture, physical measures like cold water immersion, and electrical stimulations, TENS, may be of benefit in the selected patients. I think the first one is the glycemic control, and then this is very good. Non-pharmacological management, like your psychotherapy, acupuncture, or cold water immersion, or the electrical stimulation, and then only your medications, because medications have a lot of the side effects as far as the neuropathy medications are concerned. So now this is the treatment algorithm for the painful diabetic neuropathy. So is the pain due to the distal symmetrical polyneuropathy confirmed? No. So refer to the pain clinic. So yes, in your diabetes, it is all because of the diabetic distal symmetric polyneuropathy. Assess the comorbidities. I told you the other comorbidities, a potential for the adverse effects, drug interactions, cost to the selected initial therapy from the three choices below. So what are the choices you have? Voltage gated drugs like pregabalin and gabapentin, that is one subset. And then you have the serotonin norepinephrine reuptake inhibitors like duloxetine, that is another drug. And then the age-old drug is a secondary amine tricyclic antidepressants like nortriptyline and desipramine. So out of them, we often use the nortriptyline, we use duloxetine, we use the pregabalin, and we use the gabapentin. Now the combination of the pregabalin and duloxetine is available, and combination of the gabapentin and duloxetine is available, and we use the nortriptyline also. Some formulations, they will have the nortriptyline, duloxetine, and pregabalin also. But these combinations, you should be very, very careful because of the more and more side effects. So it's always better to use the one drug, wait for about 15 days to the 1 month, and then you can add the second drug. Again, wait for the 15 days to the 1 month, and then you can add the third drug. So that is how we have to treat the diabetic neuropathy. Otherwise, once you put all these three drugs in a single person at a night time, and definitely they will have a lot of the side effects, especially to the brain, side effects to the lungs, the side effects to your gut, and definitely they choose other pathies, maybe Ramdev Pati or maybe Ayurveda, Unani, etc., etc. So they may lose your the patient's confidence on the allopathy. So that should not be there because this diabetic neuropathy is a chronic problem. So already the patient is a 15 years or 20 years of the diabetic life. No hurry in treating the diabetic neuropathy. I mean, 1 month or 2 months cure is not possible. So it takes minimum few years. So whenever you have that long duration of the cure in any diseases, so always start with the low doses and go uptitrated. So uptitrate these dosages, and then you can add the second drug or you can add the third drug. So that is how you have to treat the chronic conditions like diabetic neuropathies. No clinically meaningful effect. Switch to the another agent from the above or try combination agent. May add the tramadol or the tapentadol. So tramadol is also very common ultraset we often use at the bedtime these population, and some people they get good response to the ultraset the night time. Then we tell them to take the off tablet in the morning time also. So if they are comfortable, so continue the off tablet. So if they have the partial response to the off tablet and they are tolerating well, then you can increase to the full tablet. So never give ultraset full tablet in the morning times. So they cause some gastritis, they cause some giddiness, etc. And definitely the people loses the confidence on you. So before prescribing any drug, you should know all the side effects of these drugs and then act accordingly. Always goes with a low dose only. Now semi-ultraset is also available. Management of the autonomic neuropathy, symptomatic management, a postural hypotension, so supportive garments, supplementary salt. Again, if the patient is in hypertensive, high hypertension, so we may not give the supplementary salt. Suppose if the patient is in CKD, again the salt restriction must be there. So these are all applicable to those people who are not having severe hypertension, who are not having CKD. Okay, and then the low dose fludrocortisone. So these are available for your postural hypertension treatment. For gastroparesis, multiple small feeds, that is the best advice. Otherwise, if they take the large meals, so again the vomiting is the rule. So metoclopramide, so that can be useful as a SOS basis, and jejunostomy is not possible for all the population. In the constipation, you have the different laxatives. So the fiber laxatives are there, and you have the cremaphin plus, you have the dulcolax, etc. And cystopathies, so self-catheterization is possible. In very few patients, we advise the cystopathy. Here the Dikshit will comment on this. Bethanechol, so is the one drug to be used as a symptomatic measures. Diarrhea, anti-motility agents, loperamide, etc. And antibiotics, now the rifaximin is available, or your ciprofloxacin, or your doxycycline, or your tetracyclines on a 5 days course or 3 days course, not for the prolonged uses. Erectile dysfunction is a very, very common in chronic diabetes, a hidden complication, a secret complication. Now these are the very beautiful drugs. The PDE5 inhibitors are available. They can be useful in those population. But one warning to them is those people who are on the nitrates. So better to avoid the Viagra, sildenafil. So that is very important. Otherwise, they will have a postural hypotension and death also possible. A gustatory sweating, a tropical glycopyridine. So thank you very much for your patient hearing. And if you have any doubts, I'm very happy to